Okay, so as we were learning about the DSM-5, it says to improve clinical utility, it means the use of the DSM. It's organized on developmental and lifespan considerations. So it begins with the diagnosis thought to reflect developmental processes that manifest early in life, that we kind of talked about. And then example, neurodevelopmental and schizophrenia spectrum and other psychotic disorders. So followed by adolescent and young adult bipolar, depressive, and anxiety, and ends with diagnosis relevant to adulthood or later in life issues like neurocognitive disorders. So a similar approach takes place in each of the chapters. So each of the chapters, it's created in that a way to a comprehensive use of lifespan information as a way to assist in diagnostic decision making. Okay. So, a mental disorder, just to recap, like a mental disorder is a syndrome characterized by clinically significant disturbance in an individual in their cognition, emotion, regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying their mental functioning. So mental disorders are usually associated with significant distress in social, remember we said talk about this, social, occupational, or other important activities. So an expectable or culturally approved response to a common stressor or loss, such as death or of a loved one, is not a mental disorder, okay? Socially deviant behavior and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction in the individual, just like the things that we talked about, conduct disorder, ODD, all of those. So they represent deviance from a dysfunction, okay, in the individual as described, okay? Also, are they dangerous to themselves or others, okay? So an overview of what we'll be talking about here is the neurodevelopmental disorders, autism, social communication disorder, attention deficit, intellectual disability, and specific learning disorders, okay? So the neurodevelopmental disorders, the DSM splits childhood disorders into two chapters, okay? Neurodevelopmental disorders, and then disruptive impulse control and conduct disorders, the ones that we just went through. So one are behavioral, the other are neurodevelopmental, okay? So DSM-5 combines some of these disorders, okay? Autistic disorder, Asperger's disorder, which they did away with Asperger's from 4 into 5, and they included that into autistic disorder. Hello?
Yeah.
And created a spectrum, okay? So, and pervasive developmental disorders not otherwise specified combined into autism spectrum disorder, okay? So, oh, shoot. So these disorders, intellectual disability disorder replaces the term mental retardation. So they had that as a term before, so now it's intellectual disability, and the severity is determined by the adaptive functioning rather than their IQ. So it's not based upon their IQ anymore. It's based upon how they adapt in life, okay? And then communication disorders are renamed into introduction of social communication disorders. So not just communication, but social communication as well. So ADHD, onset of symptoms by age 12 rather than 7. So these are the differences between the DSM-5 and DSM-4. So onset of symptoms by age 12 rather than 7, and a reduction in number of needed symptoms from adults from 6 for children under 17 and 5 for individuals over 17. So they changed those from the past. So those are the differences. Okay, so here's what we were talking about, neurodevelopmental disorders. So there's a move away from relying exclusively on the IQ test that they used to do. So I remember going through school and they would give you these tests all the time too. It would be based upon your intelligence quotient. And now they kind of did away with that, and they are making it measurable upon adaptive functioning now. Okay. So the DSM-4 criteria had required an IQ score of 70 as the cutoff diagnosis. So they've done away with that. The new criteria recommends IQ testing and describes deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. What's that mean, you think? Tell me what we just read. What's that mean? Deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. What's that mean?
They do kind of executive functioning tests. For my son, for example, we keep the score like every 2 years. He has one through public schools. He's in a special school. And so they don't evaluate only like the academic skills or IQ, that they have adapted IQ tests too. But actually we are more, we want him to have more executive functioning. I think that's the goal for all the kids on a spectrum.
Yes.
So I like that they have all this adapted, and that we can have goals as you do the tests. You have the results of the tests, and you know where you need to work on, and have goals and a plan for therapies, which is really helpful.
Yes.
But that means that, yeah, we are always trying to work toward independence, which can be really difficult for kids at level 3, for example, of support.
Yeah. So that's cool that they did away with just the IQ, right, of someone, and they're looking more at how they can be more independent, or how much dependent are they on others. So I like that. So let me ask you this, since you've been through some of these tests and assessments, right?
Yeah.
Okay.
I have always meetings and
Okay. So as you've been through that, let me ask you this. How do you feel about those assessments? And the reason why I'm asking that, do you think any of those things are subjective rather than objective?
I have been this discussion for so long with the psychologists from school and from the therapy center, and they are aware of the limitation of the tests, because when you're talking about the kid with autism, they are not constant. So like, okay, they have this day set up for the test, and then someone shows up. One thing that I always ask them, and to have a familiar face when they are doing it. So a psychologist from the district, from the public school, comes to apply the test, but he has to have his teacher or a para with him, because he would not do anything that I know that he's capable to do, having someone that he never met before, or someone that he he meets every 2 years. So one of the things that I always ask is to have one that works with him every day in a daily basis, that he likes the person and he's comfortable and confident around that person. So that the one thing that I think it's important they always have his teacher or a para or the therapist that he knows with him. So that will help him. But even though having someone familiar, and it depends of the day, you would apply a test in a day that he is not well, and the score will be terrible. And you say, okay, he's not able to do this and that. And actually, I know that he is because I am with him every day. So
Yeah.
some things, it's hard to measure things when you're talking about like autism, because
Yeah.
lots of things are going on, are playing in there. So like the day, if it's raining, it affects his mood. If he has some sensory issues, and he's not, he's not organized in his thoughts and in his emotions, all of that affects. So many things can affect a test.
Yes.
So it's random. They like, oh, that day we're gonna do the test with the students. Maybe that day was not the best day, and then the score will be like that. So I always prefer to have the meetings with the therapists that are working with him on a daily basis, because we have weekly meetings, and then I know what's going on really, because that is more consistent. We are always reevaluating. It's like in counseling that we are, you have a, I don't know, weekly meeting with the client, and you're following week by week. And that's much better than this kind of tests. Usually they do once a year or every 2 years, but
Yeah.
it's not accurate. It's hard to have accurate results. It's really hard.
Yeah, absolutely. Yeah, too many variables, right? Yeah, absolutely. But so I remember okay, when I was hiring somebody before in the job previous, we would do personality tests like the DISC or whatever, right? And so what I would tell people who else are doing the hiring is we only weigh the assessments at about 25% of the hiring, meaning we can't just go off of what the assessment says. We have to go off the whole thing, like the whole
Yeah.
interview process and all that stuff too.
Yeah.
Because somebody's personality, maybe whatever happens within that assessment could be based upon the day that they're having, just like you're talking about,
Yeah.
or their mood or something like that too. So I said, don't always base it off of, the assessments and stuff. So I
Yeah.
love that you just said
That's
that.
true.
Mhm.
Yeah.
Good. That's awesome. Thank you. I appreciate you
Thank you.
talking about that. Yeah. Okay. Let's go through just a little bit of this. This is in the early stages of life, right? So a child's brain is not a miniature replica of an adult's brain, of course, but rather a brain in continual development, growing at times tremendously, subject to endless modifications and connections due to the continual stimulation provided by the environment in which it develops. So what else can we talk about that? So what they're saying is our environment makes a difference. Functioning makes a difference. So many others. So our socioeconomics, all of those things make a difference in the development of the person, the environment, all that. So it's essential to understand that development of the nervous system along with this, right? And its different stages in order to understand the deficits that can arise from an abnormal brain development or be caused by damage at an early age. So that's the holistic part of the whole body, right? It's not just the brain development, but it's like what else is happening within the body that contributes to their development. So depending upon the time when these abnormalities or damages occur, is it during pregnancy, the perinatal period, or infancy of the child, right? Different things can happen. Even upon birth, things can happen upon birth that affect, right? So the impact on these individuals will vary through this, okay? Some of these disorders included in this classification can be completely resolved by appropriate intervention. I love that. So if we understand it, we can provide interventions and therapy to assist in it. Not always, of course, but it can help in any stage of that, right? Others are chronic, okay? But an adequate intervention is nevertheless essential because it is impossible to alleviate to a greater or lesser extent, and in some cases, possibly eliminate the negative consequences or symptoms caused by the disorder in question. So, just like Erica, you were talking about, weekly, you've got to check in with all of this stuff to say, see where they're at developmentally through this whole course. And you know, counseling is the exact same way because people, and I was saying this earlier today, we go through stages in our life. Even if there's no developmental issues, we still go through stages in our life where we are always changing and we want to always change. How boring would that be if we're not, right?
Yeah.
But we're always changing. The other part is growing in the image of Christ, right? We're always changing in that respect as well. So anyway, I love this part of it because it's just teaching us that, hey, whatever is going on, whether there's some developmental issue or not, there's always assessments that can go on that can help us with interventions and counseling. So just want to impress upon y'all, assessments are a good thing in anything
I
that you
really
do.
struggle with assessments. And I know that that's like my own personal bias because as I mentioned yesterday, my daughter, if we had based her life and our parenting on her assessments, she may or may not function at McDonald's, but she's got a master's degree and is on the leadership team at the school she teaches at. But yet her IQ test said that she was, I think her IQ test ordered at 71. Um there, I mean, that's not functionally possible based on what she accomplished. And so I really struggle with giving assessments a whole lot of value.
So what I was kind of saying before was when we do assessments, it's about 25% of what we should be measuring things, right? So like the personality tests and all that stuff that I was saying, I totally agree with you. Yeah. Because she defied it all, you know, if you were just to go off of assessments, she defied all that. And I think I was asking, you know, Erica before is like, a lot of things can be subjective, right, with some
Oh, yeah.
individual.
Sure.
And yeah, so it could be subjective with the people who are doing the assessments rather than taking in the holistic part of like, what do the parents think? What's a doctor think? What do the assessments say? What do other counselors say? You see what I'm saying? In getting the whole community involved in the care. Does that make sense?
Yeah,
Yeah.
totally.
Yeah, Cindy, I would hate to go off of just assessments because then that just puts us in a box, right?
Yeah, exactly. Yeah.
Yeah.
And many times the assessment is focused on your weaknesses, I would say, not strengths. If you're
Oh,
talking
good
about
point.
academic, for example, the academics for my son, of course, he reads he's 14 and he reads like a first grade, or his comprehension, it's, I don't know, 3 years old maybe.
Yeah.
But he has perfect pitch and he can listen a song and memorize it, and you know, so like, okay, he has other strengths that we can work on. And I think sometimes assessments just show you that terrible picture because it's focusing on on the weaknesses, and we all have weaknesses and strengths. So we need to have the whole picture, as you said, like the holistic view.
Yeah, so good, especially in your case, and then in Cindy's case too, talking about her daughter, and if we just went off those assessments, then we wouldn't Then, and I love, Cindy, you talked about it yesterday. It's like, I didn't even tell her until later in life, about all of this stuff, because then it would have labeled her or put her in a box or whatever. And you didn't accept that either. Right, Cindy?
Right. The flip side, our youngest daughter took some assessments at a clinic, and she was diagnosed as bipolar. Her therapist said, "I don't believe this assessment." We had 4 different therapists that had worked with her. "We don't believe this assessment." So we wanted to hold off on it and wait and see if we saw more, what was going. But the clinic director insisted that she be present and be told of her diagnosis. And if we refused, he would report us to Child Protective Services. So now I know he probably had no grounds, but he scared us and threatened us into it. So she heard her assessment, and it totally freaked her out because she knew enough about bipolar to know that had some pretty negative lifetime connotations. It took a long time for her to get past that diagnosis, that in all likelihood it was 100% inaccurate.
Wow. Yeah. Yeah, that's tough. Oh, so let's go through autism spectrum disorder here. So they are a group of developmental disabilities that can cause serious or even chronic socialization, communication, and behavioral problems. The way in which these changes are manifested varies greatly from one child to another, hence referring to a spectrum or continuum of disorders, right? So meaning that there are different ways in which the symptoms of these type of disorders appear, and the severity of symptoms varies from case to case. The clinical profile is neither uniform nor absolutely demarcated. It oscillates, ranging from high to low affect, varies with time, and is influenced by factors such as the degree of associated intellectual ability to access or access to specialized support. People with ASD process information in their brain differently than others, and they develop at different rates in each area. They present with clinically significant and persistent difficulties in social communication, marked difficulty in nonverbal and verbal communication used in interactions, lack of social reciprocity, and difficulty developing and maintaining peer relationships appropriate to their developmental level. Stereotypical motor or verbal behavior, unusual sensory behavior, and excessive adherence to routines and ritualistic patterns of behavior, and limited interests. So, autism spectrum consolidates prior diagnosis of autism. So, and Erica, you might know all this, but so like the DSM-4 had a thing called Asperger's, and you guys have probably had heard of that. So the DSM kind of did away with those and combined some, right? So it consolidates prior diagnosis of autism, Asperger's disorder, PDD-NOS. I'm trying to remember what that is. Do you know what that is?
Yeah, it's I don't remember exactly now, but that was actually the first diagnosis that first doctor that I went, he gave, because he used still the DSM-4. So that is a delay in the development. And then the second one gave us the autism diagnosis. But the first one said that was that. I forgot now, but you just read that slide before that. or 2 slides before that. That is the
Okay,
the
gotcha.
name of that.
So it's pervasive
Yeah,
developmental
pervasive.
disorder, not
Yes.
otherwise
Yeah.
specified.
That was that.
Yeah.
Otherwise
Okay.
specified, exactly.
Okay.
And
Childhood.
yeah, when the first doctor told me that, I was like, what's that mean?
Yes.
What exactly that means? But yeah, then the next the 5 DSM-5 changes.
Yeah. Yes, absolutely. Yeah. Then childhood disintegrative disorder, disintegrative disorder, and then Rett disorder.
Rett
So-
disorder. Mhm.
Yeah, and then deficits are now characterized in 2 domains: social communication and social interaction, previously separate domains. So now they're combined. Deficits are now characterized in 2 domains: social communication and social interaction, and then repetitive behavior. So social communication and interaction, and then repetitive behavior are the 2 domains. Deficits should be present in the early developmental period, but cut off of 3 years of age eliminated. So, so they can probably, because it's not diagnosed so much, they probably cut off the 3 years so that later in their childhood or in life they could still be diagnosed with it. Does that make sense?
Yeah.
So severity included as a specifier, requiring support, requiring substantial support, or requiring very substantial support. Okay. Remember the 2 system domains in autism: social communication and interaction, and then restricted or repetitive behavior. Those can be met currently or by history alone. The inclusion of the specifiers that we talked about, and then primary diagnosis followed by the number of the specifier, right? Remember the specifiers: requiring support, substantial support, or very substantial.
Yeah, that's what we call the level 1 interventory.
Yeah, level 1, 2, and 3. Yeah,
Mhm.
requiring support very much, and so on. Okay. Here are the severity levels, if you guys want to read through those, right? So level 3, required very much. So severe deficits in verbal and nonverbal communication skills cause severe impairments in functioning, very limited in initiation of social interactions, and minimal response to social overtures from others. For example, a person with few words of intelligible speech who rarely initiates interaction, and when he or she does, makes unusual approaches to meet needs only in response to only very direct social approaches.
Mhm.
So that's the social communication. Then remember the 2 domains, right? Then restrictive repetitive behaviors look like this in level 3: inflexibility of behavior, extreme difficulty coping with change, or other restricted repetitive behaviors markedly interfere with functioning in all of the spheres, right? Great distress, difficulty changing focus or action. All the way down to, so level 2 and level 1 require the support that's required for each. So social, remember, and restrictive or repetitive behaviors. So then the next one's social communication disorder. So we won't go through all of these, but quickly, okay? Social communication disorder: persistent difficulties in the social use of verbal and nonverbal communication as manifested by the following: deficits in using communication for social purposes, such as greetings and sharing information in a manner that is appropriate for the social context. So that really, you look at it, a lot of this stuff is subjective, right? Unless it's blatantly, obvious, right? So that's why it makes it tough. The spectrum stuff makes it tough, right? Because there's um, no line, no delineated line. So then the next is impairment of the ability to change, communication to match context or the needs of the listener. Example, inside or outside voice, right? Difficulties following rules of the conversation and storytelling, taking turns, rephrasing when understood, blah, blah, blah. So difficulty understanding what is not explicitly stated. So this is social communication disorder. Deficits result in functional limitations in effective communication, social participation, academic achievement, or occupational performance. So symptoms are not due to another medical or neurological condition or low abilities in word structure and grammar, and not better explained by autism and intellectual disability. So it must be present. So here's another qualifier, must be present in childhood, even if the symptoms are not recognized until later. So it means it can be diagnosed at a later date because we don't always take people in at 3 years old. That's kind of what they was saying before. So here's a big one, right? Attention deficit or hyperactivity disorder, ADHD. During the 1980s and 1990s, approximately 50% of all children referred to outpatient mental health treatment clinics were referred based on concerns about possible ADHD. That's a lot. 50% of all children. I can remember, here's, okay. So me, I was the class clown, okay, in school. I was always getting in trouble. So, they had the whiteboards, and then what the teacher would do is write your name. And if you had got 2 check marks after your name, you couldn't go out to recess. I'm like, you guys are just hurting yourself, because wouldn't you want me to go out and burn all of this energy and everything? So you making me stay in is just going to make your life worse, So that's the way I felt about that stuff too. So could they have said, "Well, he's got ADHD"? Well, to me, it's like they gave homework in school, and I got it done fairly quickly, and then I was bored. So that's why, I was always getting in trouble all the time. So could they have diagnosed me with that? Yeah, probably. Glad they didn't. But in the 80s and 90s, that happened a lot. That was the buzzword. Man, I've got ADHD. So it was like, it was like an excuse or something like that too. So I love, that, we have to really buckle down and put the requirements with it and everything too before it's diagnosed. So if you look at the next thing, 3 to 5% of school-age children in the US struggle with ADHD. 3 to 5%. And it's considered a lifelong disorder. Approximately 70% of children diagnosed with ADHD will struggle with symptoms throughout their whole life. So it's diagnosed more frequently in boys, almost 4 times as many, right? Boys externalize symptoms, whereas girls internalize symptoms. What do you think that means? Tell me what you think that means. If boys externalize the symptoms, whereas girls internalize them.
Well, boys tend to display ADHD by, talking, being hyperactive, not staying in their seat. Girls tend to demonstrate it more with things that might mirror anxiety. At least that's what I've read.
Yeah, very good. That's good. That's perfect. Absolutely. So boys act out more, right? Yeah, very good. No single cause explanation for the cause of ADHD has been identified. No single cause. So a lot of different causes, right? Possible explanations include neurobiological irregularities, neurochemical that word, environmental toxins, diet, and family factors. It is evident that neurological deficits are part of the symptom pattern. So meaning developed neurologically. To me, I would include all of that stuff, right? Environmental, diet is another big one. Another thing that they're going, and I just saw a video on it this morning, is talking about red dye 40, right? Red dye 40 is being a huge contributor to ADHD in children. Do some looking on that, you guys, whenever you have a moment. And make your own, draw your own conclusions from it. But so the ADHD, there's two symptom domains: inattention and hyperactivity or impulsivity. So those two things. So at least 6 symptoms in one domain are required for the diagnosis. Persisted for at least 6 months to a degree inconsistent with developmental level with negative impact on social and academic occupational domains. Okay, examples have been added to the criterion items to facilitate application in the lifespan. The onset criterion has been changed. Remember, they've lowered that symptoms that caused impairment were present before age 7. Several inattentive or hyperactive impulsive symptoms were present prior to the age of 12. Symptom threshold has been made for adults. Comorbid diagnosis with autism spectrum is not allowed, or is now allowed. I'm sorry. I was like, that didn't make sense. Is now allowed, okay? So they can be diagnosed with ADHD along with, in the past, it was one or the other, right? So now they're allowing it with both. Through what? Through research, watching behaviors, things like that, okay? Empirical evidence is what they would call it. Okay, so inattention, the very first part, remember we talked about inattention, impulsivity, all those things. Fails to pay close attention to details, and then there's careless mistakes being made. Often can't sustain attention, does not seem to listen when spoken to directly, does not follow through and fails to finish, has difficulty organizing tasks and activities, avoids dislikes, and is reluctant to engage in tasks with sustained attention, loses things, distracted, and forgetful. So the second part is hyperactive impulsivity. So remember, inattention, and then this one, second part is hyperactive impulsivity, right? So not solely oppositional or failure to understand. Often fidgets, taps, or squirms. Leaves seat, runs about and climbs, can't play or work quietly, talks excessively, blurts out, difficulty waiting turns, interrupts, and intrudes. That's mostly kids, right? So, and then ADHD criteria is if you're looking through your DSM, so those were A criteria, right? A criteria there, 1 and 2, and now B through E criteria, okay? Several inattentive or hyperactive impulsive symptoms were present prior to the age of 12. Prior to the age of 12, several inattentive or hyperactive impulsive symptoms are present in 1 or more settings: home, work, school, family. Remember those. There is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. Remember, those are in all of them, it seems, right? The symptoms are not better explained by another mental disorder. So that's your qualifiers, right? So then there's intellectual disability. You guys can kind of read through those. Three criteria. Well, let's do it real quick. Three criteria must be met for intellectual disabilities: deficits in intellectual functions, reasoning, problem solving, abstract thinking, academic learning, and so on. Deficits in adaptive functioning, failure to meet developmental and social cultural standards, need ongoing support to participate in daily life, and then the opposite of deficits during the developmental period. Onset of deficits during these developmental periods. So here's the an important part, right? So there's the severity levels. So as you're looking through your DSM, there's severity levels to these things. So then as you diagnose them with intellectual disability, you want to put in with the diagnosis, the severity level, okay? So mild severity level, the conceptual domain is generally school age difficulties in academic skills. And then in adults, abstract thinking, executive functioning, and short-term memory. So in the social domain, there's difficulty in accurately perceiving peers or social cues. Communication is concrete or immature for their age. Difficulties in regulating emotions, low awareness in social settings, and at risk to be manipulated by others. Okay. Practical domain, that was social, this is practical, may need support in daily living tasks, grocery shopping, transportation, money management, etc. Recreational skills are similar, whereas the judgment and organization is lacking and can procure employment and jobs that do not require conceptual skills. Okay, that's the mild. So let's look at moderate, and then there's severe, okay? So you can look at those. Language and academic skills develop slowly, whereas there's just difficulties in the first. Adults, academic skill development at an elementary level, whereas in the first it was abstract thinking, executive functioning, all have issues, okay? Social domain, able to communicate or relate with others at a base level, whereas it was difficulty perceiving peers or social cues. So it just gets harder, right? They may not perceive social cues, need assistance in life, and so on. So let's look at severe. Their conceptual skills are limited, little understanding of written language, caretaker needed. So at the severe level, they will most likely not be able to be independent. They even require support for all activities of daily life, bathing, dressing, elimination, everything. Supervision at all times, cannot make responsible decisions for self or others, okay? So then when you have those, if they're diagnosed with that, you have to say, how severe is the level? Just remember that, okay?
Mhm.
So as we look at intellectual disability, the differential diagnosis, what else could it be, right? Major and mild neurocognitive disorders. Communication disorders and specific learning disorders do not show deficits in intellectual or adaptive behavior, or is it autism spectrum disorder? So let's look at, that's why the autism spectrum disorder is so important to learn and understand, because of the differences in everything too. There's a lot to that, a lot to it. So you can also diagnose them. So comorbidity can be, all of these things can be diagnosed with intellectual disability. So then specific learning disorders and so on, dyslexia. Okay. So specific learning disorders have specifiers, right? So remember that when you're diagnosing it, and we have specifiers, okay? Mild, moderate, and severe. And then differential diagnosis. What else can it be? We want to eliminate all the other ones to be able to get to it, okay? Okay. Ready to practice?
That's good.
A 2-year-old boy presents following concerns that he is not yet using single words. He also seems disinterested in engaging with other children. He occasionally engages with his parents, but less than what they think he should be engaging with them. He doesn't tend to look at them much, and they have difficulty maintaining eye contact with him. When he wants something, he pulls them to where the object is and screams. He doesn't point like other children. His parents have also noticed that he doesn't play in the same way as other children at his age. He tends to line up toys or plays with certain aspects of them, such as the car doors. He doesn't use the toys in the imaginative way that other children would. When his toys are moved, he becomes very upset. He tends to become distressed when he thinks there's a change around the house. In contrast, he is not concerned with either of his parents leave the house. Help me diagnose this 2-year-old boy.
Yeah. Yeah, there's a lot of signs of autism here. A lot. Personally, I was never really concerned about language, because I believe that a lot of children, they can develop language, verbal communication later, like 3 years old. Sometimes, especially boys, sometimes they develop verbal language later. But the other signs are really important, like eye contact, being aware when the parents are there or leave. And those, most of them were the things that made me look for a diagnosis, because he was not talking, but that was not my problem.
Yeah.
I know that kids can have delayed in the verbal language, but the other things, I knew that the milestones about being aware of when your parent is there, is leaving the attachment, playing with the toy properly, things like that are really big signs.
Yes. Well, so let's go to the DSM. And so as you go through this, what makes, how do we diagnose, right? I'm trying to find it.
Yeah, I think what you just spoke to on this was just the deficits in developing, maintaining, understanding relationships, ranging from, difficulties adjusting versus to sharing imaginative play, or,
Mhm.
the absence or interest of others.
Mhm. Yeah.
Yeah, what page do you see it on?
56.
Oh, 56. Thank you. Ah, yes. Okay. Very good. So let's do this. So if we think it's autism, so you've diagnosed them with autism, talk to me about specifiers. What's that look like? That's your second part of it, is the specifier. So remember what those were?
Mm.
The levels.
levels. Yeah, honestly, I think at a 2-year-old age, it's really hard to talk about levels
Yeah, sure
because
would
you're
be.
in early development. Like I could see like when he was diagnosed at 2 years old, he just said, well, they said he had autism for sure, but we cannot specify the level right now
Yeah,
because he's
absolutely.
only 2. But
Yeah.
as he was growing, the gap from the when you compared him to other children of his age, the gap was just increasing. When he was 2, even some people would say, "Oh no, he's fine," and I was looking for, no, there's something going on. No, he's fine. He's not talking yet. But I was with him the whole time, and I knew that there are other things going on. But people would say that he's fine because it's a 2-year-old. He was going around playing. He didn't have so much motor stereotypies. So that was one thing that people look for. But I knew that he was not playing properly with the toys at home. He was not he's not paying attention when you called him by his name. And there are other things that I knew. But when they are 2, it's really hard to define the level. But that is as they are growing and you see that the support is increasing compared to other children.
Yes, very good.
And also, I believe that early intervention, it can help a lot. I have seen many kids that they started early intervention, lots of therapies, and they are, they are moving from level 3 to 2 or level 2 to 1. That can happen too.
Yes, very good. Absolutely. Yeah, and really just what you just said nails it on all the other ones too. Early intervention is always best on anything, right? Right? Even
Yeah,
medical
on
stuff,
anything.
early intervention is the best,
Yeah.
right? Because if you
Yeah.
live with something for so long, it just keeps getting worse and worse and worse on some things, not everything, but
Yeah.
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 Good.
Yeah.
Thank you for that. That's good. So, okay, good. Good job, guys. Let's see what else we got here. Yeah, let's go on. Okay. All right. We are cooking. So I wanted to get to some other substantial ones. Pull this up. Okay, we're going to get it in some here. Okay. Depression. Okay. Depressive disorders. So let me ask you this. So what were or are your perceptions about depression? What's that? When you hear that word, what's that mean to you? What's depression mean to you? When you hear that word, somebody says, I'm depressed. What's it mean to you?
I think it's more than just sadness, because I think a lot of people, when they say depressed, they're just sad.
Yeah.
It's an extended period. It's not just a day or two and you kind of get over it and you move on, but it's an extended period where it actually hinders your life, your social, interactions, the ability sometimes even to work and all of that. So it's not just sadness, and I think I sometimes feel like this generation tends to use it as a catchphrase. Everything is, they're depressed about everything. And it's like, no, you really don't know what that means. So so I think I'd say it's just definitely more than just being sad about something, but it's really something that is like almost debilitating as far as like your ability to continue to move forward in your life and do things that would normally would normally be able to do.
That's good.
Mhm.
Yeah, it's a lot more than just sadness, isn't it, Felicia?
Mhm.
Trying to look for it in the DSM here. So, okay, so let's go through diagnosing depression and mania. Okay. So we're heading towards a lot of things like bipolar and things like that too. So diagnosing depression and mania. Clinicians must consider numerous depressive syndromes, including major depressive disorder, persistent depressive disorder, and depressive episodes of bipolar disorders. Okay. So what this is saying is there's a lot of differences so there's depression, but there's a lot of differences in those depressions and how you're going to diagnose it. And that's where the keys are and why it's so important to understand the differences between each of them, okay? So the opposite of depressed moods are mania and its variants, hypomania, cyclothymic disorder. Okay, so cyclothymic is just like it says, cycle, right? So your cycle between depression and mania. Okay, but it's on a smaller scale. So in bipolar, we'll get to it, but bipolar, the mania is maybe even more extensive, but cyclothymic is more on a you go between both of them, okay? Once we have a diagnosis, we consider the question of comorbidity of these mood disorders, okay? So that's why these are so important. Depression shares borderlands. What? Depression shares borderlands. I don't know what that means. With bereavement and other losses, okay? So we can have grief and things like that too, but that's not depression. So grief, if you look at grief, the difference between grief and depression is what? What do you think? What's the difference between grief and depression?
Grief, we have a specific situation that happened and it probably has a time for that, like it lasts for a period of time. Like you lose someone and you go through a grief because you have lost a loved one.
Yeah, and there's
But then-
stages. Yeah, in
Yeah,
grief,
the
there's
stages.
stages, right? So the end stage of grief is acceptance.
Acceptance.
And there's hope on the other side of
Mhm.
grief that it's all going to get better, all that stuff too. With depression, there's no hope, right? So see what I'm saying? So there's no like stages that you're going to go through to get better in depression. It could always be there. Now there's things that we can do, interventions, medication, things like that. So yeah, good job. You're exactly right. Time and specific situations. Good job.
Sorry,
So
what page are you, Professor?
I don't know. I was kind of looking at
177.
177.
Thank you. Thank you.
Let's look at that.
You were reading and I was trying to find.
Yeah, so the
What is
depressive
the title on that? Since I have a different book,
depressive disorders.
just a person. Okay.
Yeah.
Thanks.
Okay, so if you look at these, so look at the colors on here, so the lines. So these are what, if you were to plot them out, this is what they all look like. So an average mood, right, not up or down, is right in the middle. Then major depressive disorder, look at the blue. You see the line that goes along and then it goes way down and then back up again. So that's major depression. So you're going to stay in it. It's going to go way down and you're going to stay in it for a little bit. at least 2 weeks. Okay. Persistent disorder, persistent depressive disorder, that's in the green. So that, see where that is? So for 2 years, you experience depression the whole time. Persistent depressive disorder. See where it's at down there? Your mood is low below the line for 2 years. So the third one is bipolar. So you see where you're in there, bipolar 1 is with mania. Okay, so you're going along and see the difference between, see where the arrow is, where it's up and down. The first one's bipolar 1, where there's mania, and then it goes way down in depression. So you're high, or you're really high, or you're really low. Okay, and then bipolar 2 is, it's lower in mania, but it's still high, higher, if you will, in depression. You see that, guys? And then the third is the cyclothymia, where you're cycling through mania and depression, mania, depression, mania, depression. So that would help you kind of get a picture of each one of these. So major depressive disorder, should we look at that? And that's on page 183 if you're looking in there. So 5 or more of the following symptoms during a 2-week period, okay? 5 or more of the same symptoms in a 2-week period and represent a change from previous functioning. So at least one of the symptoms is either a depressed mood or a loss of interest or pleasure, okay? Depressed mood or loss of interest or pleasure. Somebody want to read that first part? Number 1 in there.
Depressed mood most of the day, nearly every day, as indicated by either subjective report, feels sad, empty, hopeless, or observation made by others. An example appears tearful. Note in children and adolescents can be irritable mood.
Irritable mood in children or adolescents. Because they don't know how to do what? Talk about their emotions and things like that. So number 2. Somebody read that? Okay.
Sorry, markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by either subjective account or observation.
Okay, keep going if you can.
Significant weight loss when not dieting or weight gain. In example, a change of more than 5% of body weight in a month, or decrease or increase in appetite nearly every day. In children, consider failure to make expected weight gain. 4, insomnia or hypersomnia nearly every day. 5, psychomotor agitation or retardation nearly every day. Observable by others, not merely subjective feelings or restlessness or being slowed down. 6, fatigue or loss of energy nearly every day. 7, feelings of worthlessness or excessive or inappropriate guilt, which may be delusional nearly every day, not merely self-reproach or guilt about being sick. 8, diminished ability to think or concentrate, indecisiveness nearly every day, either by subjective account or as observed by others. And last, recurrent thoughts of death, not just fear of dying, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing.
Good, thank you. And then B, as we go on, the symptoms cause clinically significant distress or impairment, and guess what? Social, occupational, family, right? All of these functioning, okay? And then C, the episode is not attributable to physiological effects of a substance or another medical condition. So it's not the drugs they're taking or anything like that is causing this. So criteria A through C represents a major depressive episode. So then you go down to D, at least one major depressive episode is not better explained by schizoaffective disorder and is not superimposed on schizophrenia, schizophreniform disorder, delusional disorder, and so on. There has never been a manic episode or hypermanic episode. Why do they say that?
Because of the differences of the types of depression. And if it was a manic, then they would be a manic depressive person. They
Yeah.
wouldn't-
Yeah. So if we look at that, major depression, and then maybe we go over to the differential diagnosis on page 191. So manic episodes with irritable mood or with mixed features. So major depressive episodes with prominent irritable mood may be difficult to distinguish from manic episodes with irritable mood or with mixed features. This distinction requires a careful clinical evaluation of the presence of sufficient manic symptoms to meet the threshold criteria. Okay, so the other thing that I was getting at was bipolar 1, bipolar 2, or other specified bipolar and related disorders, because that has mania in it and depression. So we want to, so that's why it's so important to rule out. Another thing is, if we can find it in here, it would be the prevalence, right? So we want to look at the prevalence. 12-month, and that's on page 187, 12-month prevalence of major depressive disorder in the United States is approximately 7% for a whole year, okay? With marked differences by age group such that the prevalence in 18 to 29-year-olds individuals is threefold higher than the prevalence in individuals 60 or above. So the most reproducible finding in the epidemiology of major depressive disorders has been a higher prevalence in females. So females can be higher diagnosed at a higher rate, an effect that peaks in adolescence and then stabilizes. Women experience approximately twofold higher rates than men. Very important there, especially between menarche, I don't know what that word is, and menopause. Women report more atypical symptoms of depression characterized by hypersomnia, increased appetite, and leaden paralysis compared with men. And then you could go on down to the developmental, the course of how it's developed and so on.
But it's interesting that they mention about menarche and the menopause, because they're the two big events about the hormones. Women's
Yes.
hormones changing. So that's, again, talking about the holistic view. There are things that you can do to help.
Mhm. Absolutely. Yeah, and not knowing what to do with those hormones, right? And the change in the body and the change in
Mhm.
everything, right?
Yeah.
Good. Okay, so at least either depressed mood or loss of interest of pleasure can be one of the symptoms. Criteria: depressed mood most of the day, markedly diminished, and so on, right? So we went through those. Feelings of worthlessness. So if somebody comes in and they have all of these things, they need how many of those? Five or more of those.
Before?
Yeah, good job.
Probably.
Yeah, 5 or more of the following symptoms, right? So if they go, oh, so they say, oh man, I'm seeing 6 or 7 of those, you can start ruling out other things, right? And go for the major depressive. And this is for how long? 2 weeks at a time. Okay, so then there's persistent, which goes how long? 2 years.
2 years.
Yeah. So you can have major depressive, and that has a big dip, right? But then there's the one that's persistent that stays for a long time. We never get out of that. Diminished ability to think, recurring thoughts, symptom, recurrent suicidal ideation, and so on. So here are the specifiers, remember? So we go from that to the specifiers, okay? Single or recurrent, it could be one episode that they have. Then, is it recurrent, okay? Then, is it mild, moderate, or severe? Is it with psychotic features? Are they in partial remission, full remission, unspecified? Anxious distress, mixed, melancholic, atypical, mood congruent, major depressive disorder, and is it caused by medication too? Can they have this, and is it because of medication? So if one of the things is, even if you're taking anxiety medication, one of the side effects can be higher anxiety before it starts working, or depressed moods, suicidal ideation, things like that. So that's important to know all the side effects with medication and things like that too. Okay, when diagnosing. Okay. We talked about the prevalence, and prevalence among females is higher, 1.5 to 3 times higher. The age groups, it's prevalent more, 3 times higher in 18 to 29, more than it is 60-year-olds plus. Likelihood of onset, so here's when it comes, increases with puberty. So that's the hormonal probably aspect of it. First onset peaks in the 20s, although it is not uncommon for later. High variability in the course of this disorder. Chronic depressive symptoms increase the likelihood of personality, anxiety, and substance use disorders, and decrease the likelihood that treatment will result in full symptom resolution. Recovery begins within 3 months of onset in 40% of the clients. That's good to know. 80% will feel the recovery within 1 year. Okay. Sometimes older people who are depressed appear to feel tired, have trouble sleeping, or seem grumpy and irritable. All of those are part of the signs and symptoms, right? Confusion or attention problems caused by depression can sometimes look like Alzheimer's disease, because what? We get foggy minded, so that could look like Alzheimer's. Older adults also may have more medical conditions such as heart disease, stroke, or cancer, which may cause depressive symptoms. Or they may be taking medication with side effects that contribute to depression. Always important to understand the medication and everything that goes along with it. Some older adults may experience what doctors call vascular depression, also called arterial sclerotic depression, or subcortical ischemic depression. Vascular depression may result when blood vessels become less flexible and harden over time. becoming constricted. The hardening of vessels prevents normal blood flow to the body's organs, including the brain. With vascular depression, may also may have or be at risk for heart disease or stroke. So that's another thing. When these people come in and they're experiencing either through medication or whatever, and the major depressive, we want them to go to the doctor and get checked out body-wise, because what else is going on in the body if this is happening? And then grief for a long period of time may require treatment as well. So maybe they need help getting through the grief. Okay. Comorbidity seen with major depressive disorder, substance use disorders, panic disorder, OCD, anorexia, bulimia, borderline personality disorder. Okay. I wonder if I can play these in here. These are all good. These are videos that I have on that page. Wish I could play them on here. And then there's persistent. Remember the lines that we had? Then the persistent. And that used to be called dysthymia. So if you ever heard of dysthymia, now it's called persistent depressive disorder. It affects nearly 6% of the general adult population, but can be found in children and adolescents. Combines chronic MDD, which is the major depressive disorder, with dysthymic disorder. So then the criterion, right? So we have to look at the criteria. Depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others, for at least how long? 2 years. So remember, persistent depressive disorder has to be there for at least 2 years. So the criterion B is presence while depressed of 2 or more of the following: poor appetite or overeating, insomnia or hyperinsomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feeling of hopelessness. C, during the 2-year period of the disturbance, the individual has not been without symptoms for more than how long? 2 months. 2 months at a time. They cannot be without these symptoms for 2 months to be able to diagnose. There has never been a manic or hypomanic episode, and criteria are not met with cyclothymic disorder, meaning up and down above the mood line. Okay. Not better explained by another persistent disorder, meaning some other disorder that is for a 2-year period. Symptoms are not attributable to the effects of a substance or other medical conditions. So that's always the case in all of these. Remember, substance abuse or whatever can cause many, many different things. And then this, or medication sometimes. So the symptoms cause clinically significant impairment or distress. Then there's severity specifiers. The early onset. So the specifiers are the same, and remission is the same as MDD. Okay. Early onset is before 21. Late onset is after 21. Okay, major depression may precede persistent depressive disorder. So does that make sense? So you can't diagnose it before 2 years. So when you're going to diagnose something, it has to be major depressive until that 2-year period. And then they have to meet all those other qualifiers. Does that make sense? Okay. Specifiers are on page 184. Mild, moderate, severe, with zygotic features, partial remission, full remission, as specified, and so on. And then there's other ones like with anxious distress, mixed features. And so all of those are on different pages. So if you look at the severity, it shows on page 214 what that looks like: mild, moderate, severe, and so on. And then with anxious distress, 210 through 211, 211, and so on. Okay, to be able to specify severity and so on. So all of these, so if you look at this Maryland page 131, 132, that's in your, I think that's in your easy to diagnose or whatever, or diagnosis made easy. So this, yeah, so that's what these are. Okay, so here's the difference between MDD and PDD, right? The simple answer is the severity of it. Technically, dysthymia, which is the persistent, is, what's that say? Is a pervasive low level depression that lasts a long time, often a few years. Major depression is a discrete episode of severe depression. When gone, the patient is in remission and feels completely normal. So see the difference between the two. It's the length of time, severity, and major depression you can go into when it's gone, you'd be in remission. Okay. Then there's premenstrual disorder, substance medication-induced depressive disorder, generally caused by introduction of a substance, and so on. So let's look at the bottom one. Substances such as corticosteroid, rheumatoid arthritis medication, asthma medication, illegal steroids, methamphetamines, over-the-counter appetite suppressants, and so on, can be substances that can cause these depressive disorders. Okay. This is a good video. It's on the video page that we had, but now they're coming, out. I mean, it's been around for a while, but blood tests to determine mental health issues, so that you can go by what's the chemical makeup of the body to determine what you're low in. And so remember when we were talking about this yesterday, what are we deficient in vitamin wise, right? D, B, all of these things, iron, all of those things can contribute to our mental health issues. So this is where it's saying they can detect mental health issues by what's in your blood. Okay. Depression, so on. Okay. Okay, so what time is it here? 2:07. Let's see where we're at. Okay, so let's take like 10 minutes, come back, and then we'll continue, but I want to watch some of those videos so that they give a great overview of these things, so that it kind of show you kind of what's out there. And so then we'll kind of wrap up what this all looks like, and then go over any questions you have over the papers after we've seen these things. So what about the paper and test and all that stuff too? Here's what I'll do is I'll open up the final so you can take the final at any time. Okay. And I'll let you know what I'm looking for in all of those too. Okay. So then when you turn it in, because there's a little bit to it. So, but so you'll be familiar with what it is. Okay. 10 minutes. See you in a little bit. So one frequently blah blah blah. So hearing voices and seeing things that aren't there are more common than we think. While these experiences can be scary and confusing, it is possible to recover and get better from them, especially when we tackle issues early. Early interventions, remember? So schizophrenia is a type of psychosis with disturbed thought, perception, language, and emotion and behavior. So that's why I wanted to go through this because a lot of times psychosis is can be the difference can be diagnosed. So I want to make sure that we understand the difference between the two. Okay, schizophrenia continued. What are the different kinds of psychotic disorders? Conditions that have psychosis as a main symptoms are referred to as psychotic disorders. However, psychosis may also occur as a feature of other disorders, like what we were just talking about, mainly bipolar or major depression. Some of the more common types of psychotic disorders include schizophrenia, schizophreniform, which a schizophreniform disorder is, it consists of the same symptoms as schizophrenia, but occurs for a time period of at least 1 month, but no more than 6 months, okay? So that's the timing of it. So it can be the same, but the timing of it makes it a different diagnosis. If symptoms last longer than this period, a person is given a diagnosis of schizophrenia. So schizophrenia cannot be diagnosed before 6-month period. So it's schizophreniform. Okay, so that's important. Then the next one is schizoaffective disorder. It's characterized by persistent symptoms of psychosis resembling schizophrenia with additional periodic symptoms of mood. That's the affective part. So there's mood that goes along with it as well. Okay. Then there's delusional disorder. It's characterized by irrational or intense beliefs or suspicions, which a person believes to be true or a delusion. These beliefs may seem outlandish and impossible or fit within the realm of what is possible. Symptoms must last for a month or longer in order for someone to be diagnosed with delusional disorder. So I had somebody recently that felt like somebody snuck into their house and implanted a chip in them while they were asleep. Okay. But they were diagnosed with schizophrenia when they were young. So this delusional can go along with it, right? Then you could have brief psychotic disorders that include symptoms of psychosis that last at least 1 day, but no longer than 1 month. So they're just brief. And that could be through medication, right? Stuff like that. Symptoms are typically sudden and are oftentimes responses to stressful life situations, right? Or an event. While an individual may experience severe distress during this episode, people quickly return to their daily lives and there are no more symptoms and they do not return. Symptoms and they don't return. So it could just be one brief episode or a series of episodes, but it doesn't last longer than a month. And then they're gone. Then the last one is schizotypal disorder, okay? This is the personality disorder that can easily be confused with schizophrenia, okay? So there's a lot of the same things. So that's why this is important to diagnose. It's due to the nature of the people with schizotypal personality disorder to have magical or eccentric beliefs, unusual thoughts, and paranoia. People with schizotypal personality disorder may experience brief psychotic episodes with delusions or hallucinations, but the episodes are not as frequent, okay? Or they're not as prolonged or as intense as schizophrenia. So but they last over a long period of time too. So schizophrenia versus psychosis, the age, the typical onset of schizophrenia. So this is important, okay? Schizophrenia occurs at the age of 18, and psychosis is not necessarily age dependent. So if that's the importance of schizophrenia, is going to be diagnosed earlier on in age, okay? Individuals with schizophrenia are often unmarried. Here's another thing that's probably not in here. But people who are diagnosed with schizophrenia, 95% of them smoke cigarettes. And there's something within the tar or the nicotine that calms the mind. That's the part about it. So 95% of people smoke. And the reason is because it calms the mind. Something within the nicotine, I think. Onset. Schizophrenia has an insidious onset, while psychosis is typically abrupt. So schizophrenia is developed over time in these people and then diagnosed, where psychosis is, it could be an event that happens just like that. A family history, there's a predictive variable in schizophrenia. So sometimes it's hereditary. Drug and alcohol, less likely in schizophrenics. Direct and indirect cost is $40 billion a year for schizophrenia. So I'm not going to go through these because you guys can go through this. We've gone through a couple of this, but these are the differences. So you probably need to really go through, look at the DSM and the differences between all of them. You probably will, in your counseling, will come across somebody with schizophrenia. I mean, it's 1%, but you'll probably come across 1, 2, and if you're in the community centers and things like that, you might come across more, or hospitals, things like that. Okay. So look at the difference between schizophreniform and disorder and so on. Schizophrenia symptoms, we went through, well, you know what? Let's do this. So this is the importance of schizophrenia. 2 or more of the following, each present for a significant portion of time. During a 1-month period, at least one of these must be 1, 2, or 3. Okay. So look at this. The first part, there's delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. Minimum duration of 6 months of continuous signs. So 6 months to be diagnosed, right? There's a functional decline. And then severity can be rated by using assessment measures in Chapter 3 of the DSM. Substantially decreased level of functioning. Signs of disturbance persist for at least 6 months. Schizoaffective disorder and depressive bipolar disorder with psychotic features have been ruled out. So that's very important. The schizoaffective disorder and depressive bipolar disorders have been ruled out. No major depressive or manic episodes have occurred concurrently with active phase symptoms of schizophrenia. And if mood episodes have occurred during the active phase symptoms, they have been present for a minority of the duration of the illness. So look at the bottom one. If there is a history of autism, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least 1 month. So delusions or hallucinations. Okay, so I'll go through this part. Schizophrenia development and the course of it, okay? Emergence of psychotic features typically occurs between the late teens and mid 30s, okay? Generally in men earlier than women, okay? Onset prior to adolescence is rare. So before the age of 14, it's very rare that you'll have schizophrenia. The peak age for the first psychotic episode in schizophrenia is the early to mid 20s for males and late 20s for females. That's the peak age. Okay, typical onset includes slow and gradual development of clinically significant symptoms. Abrupt or insidious onsets they're possible, but it's usually gradual. The course and outcome of the disorder cannot be reliably predicted, and the prognosis is favorable in about 20% of those with the illness. However, complete recovery is rare. That's important to know. Regardless of the degree of recovery, most individuals with this disorder require daily living support and antipsychotic medication. Okay, so schizophrenia, the positive symptom cluster, okay? Positive symptoms, remember this, feelings or behavior changes that are added by the disorder. That's the positive, that it's added, okay? And which are not normally found in a healthy person. That's why it's called positive, because it's something added, okay? Such as believing that what other people are saying is not true, the delusion, hearing, seeing, tasting, feeling, or smelling things that others do not experience. Those are hallucinations. Okay, so active manifestations of abnormal behavior distortions of normal behavior. Examples include agitation, delusions, hallucination, and disorganized thinking or speech. So delusions are the basic characteristics of madness. Okay. And then hallucinations are experiences of sensory events without environmental input. It means that their mind has created these hallucinations, right? And they're not something that is environmentally created. Does that make sense? They can involve all the senses, but auditory hallucinations are most common. And then findings from SPECT studies. That's a SPECT study is if you look at it, single photon emission computerized tomography. I think that's the neuroimaging where they take pictures and they can see where and this Brocas area is part of the brain where they would notice it. So that may be something you want to kind of take a look at. If you're interested in working with people with schizophrenia, you'll have to know all of that stuff pretty much. Okay. So the other thing, okay, so here's the negative part. Remember we talked about positive. Now here's the negative symptoms, okay? Negative symptoms are are abilities that are lacking or missing in schizophrenic individuals, but are present in those who are non-psychotic. Absence or inefficiency of normal behavior. Examples are emotional, social withdrawal, apathy, and poverty of thought or speech. The spectrum of negative symptoms are inability to initiate and persist in activities, a relative absence of speech, anhedonia, which is the ability to experience pleasure or engage in pleasurable activities, and then flat affect. So positive means there's the delusions or hallucinations. Negative symptom clusters of schizophrenia would be not having those, but having these others. Does that make sense? Okay. So the other thing I wanted to go through. So here's right here, there's the part of other psychotic disorders that you guys can look at, and then medical treatment for each. And then the next one I wanted to look at is bipolar, okay? So that you understand the difference between those two. So bipolar disorder and disruptive mood dysregulation, DMDD, they both have similar symptoms. Clinicians may have been assigning bipolar disorder diagnosis to those severely irritable youths to ensure their access to treatment resources and services. So meaning that they were designating it bipolar because people would get more help through that way. So that means that it could be diagnosed in more people when it could have been something else. So bipolar 1 disorder, okay? Following criteria must be met for a manic episode. So bipolar 1 disorder with manic episode and major depressive episode not required for diagnosis. So, but mania is. Okay, so that's the difference between 1 and 2. Bipolar 1 has a manic episode, and it may be followed by hypomanic or major depressive episodes. But so manic episode is this: abnormally and persistently elevated or irritated mood, increased goal-directed activity or energy, and it lasting at least 1 week and present most of the day, nearly every day. Okay. Bipolar 1 disorder continued. B, during this mood disturbance and increased activity energy level, 3 or more of the following symptoms must occur. 4, if the mood is only irritable, are present in significant degree. Okay. Inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual, or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, distractibility, increase in goal, directive activity, and excessive involvement in activities. So that's the mania of it. And during this time, during manic episodes, there's generally a lot, they could be more dangerous, not dangerous to others, but themselves, like driving faster, but then there could be more alcohol consumption, drugs being used, and then more gambling. So it's more unsafe to their person, if you will. Okay. Bipolar 2, they may have hypomanic episodes, but not pure mania. Okay. So hypomanic episodes is smaller. So abnormally and persistent elevated or irritated mood, increased activity, energy lasting at least 4 consecutive days and present most of those days. B, the same criteria as in manic episodes, unequivocal change in individuals functioning, and this change is observable by others. Bipolar 2 continued, the episode is not severe enough to cause marked impairment in life. If there are psychotic features, the episode is by definition manic. Okay. And with bipolar 2, there's major depressive disorder with it. Okay. So that's the difference between 1 and 2. There's major depressive disorder. 5 of the following symptoms have been present during the same 2-week period. represented a change from previous functioning, depressed mood, marked diminished interest in pleasure, significant weight loss, insomnia or hypersomnia, psychomotor agitation or retardation nearly every day as observed by others, fatigue or loss of energy, feeling of worthlessness, and so on, diminished ability to think, recurrent thoughts of death, and so on. Symptoms cause clinically significant distress or impairment in social, occupational, and other important areas, and the episode is not attributable to the psychological effects of substance use, just like, and those are in all of them, remember, have to always take those into consideration. So here's what I was talking about in bipolar disorder, some of the features. During a manic episode, clients rarely believe that they are all ill or in need of treatment and will often resist treatment. So there's a reason for that, right? So clients may alter their personal appearance to be more sexually suggestive or flamboyant, gambling, antisocial behavior, hostility, lifetime suicidal risk, involuntary hospitalization, legal troubles, financial difficulties, and so on. So with this bipolar disorder with mania, the problem is a lot of people who are taking medication for it, when they get into a manic episode, may stop taking their medication, which is not good. And the reason is because some people really love that manic. They feel good during this mania because they've got increased energy and everything. So it could be a problem, and they could be a problem themselves because they are increasing their gambling and drinking and drug taking and all of these things that it's talking about, but it could feel good to them. Okay. Oh, look at this. So lifetime risk of suicide in individuals with bipolar disorder is 15 times greater that of the general population, and it accounts for 25% of all completed suicides, bipolar 2. That's huge. So that's why medication and interventions and all that is so important, is because of it accounts for 25% of suicides. Okay, so what is mania? Here's another important part. Mania is more than just having extra energy to burn. It's a mood disturbance that makes you abnormally energized, both physically and mentally. They love this though, right? Gives them a lot of energy. But there's other things. A manic episode can last a week or more. During that time, you may experience grandiose thoughts and take more chances than usual, regardless of the consequences. So that's gambling and risk-taking and driving and all of those things. Mania can be severe enough to require hospitalization. People with bipolar 1 disorder have had at least one episode of mania. Usually, manic episodes alternate with periods of depression. So it could look like that cyclothymia, but it's more. So it's higher in mania and lower in the depressive disorder, okay? Usually manic episodes alternate with periods of major depression. Mania is the high and depression is the low of bipolar 1, okay? So it's a higher cycle. Bipolar 1 is a higher cycle of that. Hypomania is a milder form of mania. If you're experiencing hypomania, you have higher than normal energy levels, but it's not as extreme as mania. Other people notice hypomania and it causes problems, but not to the extent that mania can. If you have hypomania, you won't need hospitalization for that. People with bipolar 2 disorder experience hypomania alternating with depression. Hypomania can also occur for other reasons, such as drug interactions and so on. Okay? Okay. So then there's PTSD. You guys can read about that. There's PTSD, and in the end here is reactive attachment disorder, and that's generally in kids. It's RAD, is what they would call it. This happens a lot you're going to find this a lot in kids that have been in foster care, adoption, and things like that. Mostly in the foster care, you're going to see a lot of reactive attachment disorder. Okay. PTSD, and it gives the criteria for that. Acute stress. The difference between acute stress disorder and PTSD is time. Okay. So just be leery of that. So they're the same, but it's just the time. So modified, let's see here. What's the time on it? I think there's one that shows the difference in the time. Pretty sure PTSD is over. I want to see what oh, here it is. No, that's not it. Where is the time on it? Where's that at? You guys know, can you find PTSD in the
I think PTSD has one or more symptoms for more than a month, and acute stress disorder has 9 or more symptoms present from 3 days to 1 month.
Yes, that's it. So that was the one. So PTSD is all of those things over a month. So you have to have all of those things for over a month. And the acute is 3 days to a month. So then after that 1 month period, it becomes diagnosed as PTSD. So the same things that happen, but it's just the timing of it. So just remember that part. It's the time in consistency of PTSD over acute. Okay. That's the important part. Thanks for finding that.
Yep.
Okay. Oh, wow. Okay. So sharing for a second. So any questions at all? Thoughts or anything? A lot to take in, isn't it?
I have a question for schizophrenia.
Okay.
How would you go about that with the believer and the unbeliever? With being out of touch with reality and the hallucinations.
Mhm.
If they're a believer, how would you approach that versus a non-believer?
Yeah, that's a great, that's a great question. I think you look at it, I mean, matter of fact, this has just happened within the last month or so. There was a person that was diagnosed with schizophrenia, but the parents or guardians and friends believe that it could be demonic
Possession.
possession, right? So, yeah, I think, you just have to be really careful on that aspect of with people, and how you approach it and all that too, because I mean, it's all caused by sin. It originated through sin, right? But then you have heredity through all of this too, right? So things can be, so sin is hereditary too, right? So generational, all of that. So how you talk about with somebody is just going to be really important.
Yeah.
How I talk to these people was, I mean, I said I totally get it. But you've had somebody that had diagnosed them with it. They had all these symptoms. I took him even through the DSM, said, here's the symptoms that they're experiencing, all of these things. And he goes, yep, this is it, this is it, this is it. Well, this is kind of what the DSM is saying. But we work through it in a spiritual way too. We could pray, we can do all of these things, but we also have to work. I guess how I would look at it is, God gives us ways of taking care of things that are through other avenues. So the reason why, in approaching it from like somebody who has a headache, right?
Mhm.
So you can take aspirin for headache, right? Or time would get rid of it or whatever. So there is ways of working through these other things in a medical way too, as well, right? Because God gave us medicine and all of those things too. Does that help? Anybody else want to have any input? Erica?
Yeah, no, just when you mentioned that, I remembered a case like years ago, more than 10 years ago in Brazil. This lady was having like hallucinations and had lots of episodes, and the family called my husband to pray because they thought that was demonic possession.
Yeah.
But he knew the family history, and he knew that her mom was being in a psychiatric hospitalizations and had a lot of issues, and other people from this lady family. So he advised them to look for a doctor and see if she would have a diagnosis. And later she was diagnosed with schizophrenia, and she started doing treatment and taking medicine, and she got better. Of course, she needs to go to the doctor often and having a psychological
Evaluation.
Evaluation. But like she goes through treatment, but having taking the medicine and having a therapist all the time, she's doing well. She had some episodes later, but really few episodes, and she's doing really well. But she goes to church, and when she's doing well, she understands the gospel and the Bible, and she's married, and her husband went through all of that with her. But she needs to really be careful. If she doesn't take her medicine, she can get worse. But yeah, but I don't know, like, I believe that she can understand what's happening with her, and she understands her diagnosis, and she, as you said, she knows that that's from original sin, that we are in a broken and fallen world, and unfortunately she has that condition, but she she's trusting God and she's doing all that she can.
Yeah, that's good. Yeah.
Yeah, that's interesting about demonic possession and schizophrenia. Because I feel like a lot of schizophrenia is, I don't know, correct me if I'm wrong, but I feel like demon possession is like external spiritual forces controlling someone internal,
Yes.
maybe.
Yes.
Whereas schizophrenia is internal struggle with past that shows out externally in external behavior.
Yeah.
Is that right, accurate, or
Yeah. I think that. Go ahead, Erica.
I think it's just that the behavior that's really scary when you see like having like when she was having like an episode, it was scary for the family.
right?
But the thing is that I believe that with demon possessions, there is a spirit, you can feel the spiritual oppression when you
Yeah.
are close to them, and many times they would speak not being themselves,
Yeah.
and not being the person, and
Right.
that was not the case.
Hmm.
So she would have like this hallucinations that people were coming toward to get her, and she was being threatened, and she would get violent,
Mhm.
like fighting with people that don't exist. So it's exactly what you said. I think like it was in her mind. She was fighting against people that she was in her imagination, or
Mhm.
she believed that thoughts, while I think she was not hurting herself. And that's important, because usually that's
Right.
that's or not hurting other people, but she would get violent and people would just, family would go away from her.
Yeah. It's good. Thank you.
Doug, I have a question.
Yeah.
What is more debilitating, the schizophrenia or split personality? And they can kind of overlap a little, can't they?
So let's see. So the difference in you said multiple personalities, that's DID.
Right, yes.
Yeah, dissociative identity. So if you look at DID, people with multiple personalities and stuff, those personalities are actually, you know what? There is a good video. I wonder if it's in this thing that I provided for y'all. Let me look. See here. There's a really good video of this young lady, and it explains it really well. Let me see here. Oh, here it is. Bring it up. One second. Share my screen. Okay, so here's a person with DID, okay? Let's take a look at this. Make sure you guys can hear it and everything. Okay.
Chrissy, I don't want you doing the strawberries.
I can wash them though, right?
And Papa, he has to have his coffee.
They're that my mom does.
And Chrissy wants to have her juice. I want to know where the pink donuts are.
Breakfast time is a busy time at the Patillo home. The only place busier than the kitchen is Christine Patillo's mind.
I'm just extra special.
Tristan, you are extra special.
I love you. I love you. But they love me.
What do we have going?
Cindy was just out.
Christine has 6 other personalities called alters
Am I Aunt Annie?
living inside her head.
You don't like blueberries in your pancakes either, do you?
I don't actually mind them. despises fruit.
all distinct and different, all with their own voice.
I can hear them if I'm paying attention. They can look out through my eyes and they can see what's ever in my peripheral.
Dada, one more.
Sure.
Try out.
That is 2-year-old Cindy. The rest of the gang, as they're called, will introduce themselves.
I'm Christine.
I'm Chrissy. I'm Tristan, the lone male.
I'm she. I am Q. I do all the beads. I'm Rim.
Christine has dissociative identity disorder, formerly known as multiple personality disorder. It's recognized by the American Psychiatric Association and affects just a fraction of 1% of the population.
I, of course, always get to play.
Who's my wife gonna partner up with?
I'll be the shuffler.
Doctors say Christine's brain got shuffled, fractured is the clinical term, when she was a little girl.
I just seem to be going the wrong direction all the time.
And that's different from when?
Funny.
Oh, that's what I'm going to do. Here, shebang.
That didn't work out well for me at all.
Christine suffered physical and emotional abuse from her father throughout her childhood and what can be politely described as torturous sexual abuse at the hands of a neighbor from the ages of 7 to 9. Her childhood, a cruel game of survival.
That was complete being imprisoned in my mind.
Drawings Christine did in therapy show the violent battles inside her head. Doctors say when the brain can't handle any more abuse, it fractures into different personalities, and each one often serves a purpose. Instead of Christine suffering the sexual abuse, Rim, a tough tomboy, would appear and absorb the shame. The alter She, a gruff 30-year-old lesbian, would come out and take on the abuse from Christine's father. But as Christine got older, the personalities that once protected her turned.
There's a little bit of a triangle scar from a tip of an iron.
Rim led Christine to the dangerous world of drugs and promiscuity. Christine waking in places with people she didn't remember. Alter She was the worst abuser.
And we have a scar on in our hairline from when she smashed a picture frame. She used to smash pots and pans on us, and we'd have really big gnarly bruises and burns. Burning was a big thing.
It went on for years.
It's so frightening to feel like you don't have access to your mind or can keep control, or that people think that you're a freak or that something's going on.
It's been a trying 26 years of marriage, to say the least, for Christopher. The couple never had children because between Christopher, Christine, and her 6 other personalities, 8 was enough. He's been husband, father, friend, and enemy, often all within the same 60-second span. The diagnosis 10 years ago answered a lot of questions for him. One question, however, never needed answering.
Why did you stay? This is my life, and this is my wife, and it's a beautiful thing, and I love being on the journey with her. Whoop, 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 whoop. Come on,
Dixie girl.
Let's go for a walk, Dixie. Come on.
After 2 decades of therapy, Christine has come to control the people living in her head.
but all is well.
It is.
The abuse from her other personalities has stopped, and Christine lives a relatively routine life. In fact, the alters are actually helping her to better integrate into society.
These are my bead people. Everything I make is one of a kind.
This is Q, who has started her own small business selling beaded jewelry. Christine watches Q do this from inside her own head and feels inspired to do more in public herself. For Q, it's more about changing others, not the 6 alters.
Different is uncomfortable for a lot of people, and we're just trying to make our different not be so spooky or so confusing to people.
One major step in that direction, the book Christine has written about her experience. One face with 7 voices, hoping to bring understanding and acceptance to a disorder so hard to comprehend.
We're at a place where we can be in society as a person with multiple personalities, and that we have an ability to talk to people and help them become more aware about a condition that is confusing and terrifying to people sometimes.
My puppy.
Ultimately, many with this illness hope to meld all the personalities back into one so they can lead a so-called normal life.
Cloud of butterflies above a purple lilac bush.
But for the Patillos, this is normal, and this is the way they'll stay.
It is my family, and it is a family that I would never want to lose.
Yes, I have a wonderful husband. I have great friends, and we've got to meet some amazing people on this journey, and we're just beginning.
And she's just a normal person, and she just has all these people that live inside her.
Christine agreed to do this story with us because she wants to pull back the curtain on this rare but certainly disturbing disorder. She's hoping sales of her book will open the door to speaking events around the country so people can better understand and accept those living with multiple personalities.
Okay. What'd you think?
Yeah, I had a student in my dance class that had
Oh.
yeah.
Hang on a second.
Yeah, it was interesting because she was very talented and skilled, but I feel like she sometimes had some hallucinations, but she definitely did the different personalities that came out at various times in dance class.
Sorry about that.
I had a friend with it, and she had breast cancer, and treatment could be a challenge because some of her personalities didn't understand what was going on in terms of treatment and that kind of thing.
Yeah. So tell me more about that.
Well, like they didn't understand, like why she lost her hair, and they just that component of her illness and the treatment and all that she had struggled to integrate that all within the personalities. And so they
Yeah.
came out more, I guess would be what was seen.
Okay. And so let me ask you this. So did she have trauma and stuff as a child?
Yeah, I don't know the extent of it all, but yes, she had
Okay.
significant childhood trauma, sexual abuse.
Yes. Okay. So I mean, it seems to happen so much when somebody with has DID, it's generally because there's been trauma from the past, usually sexual abuse or some form of abuse, and these personalities are protectors and stuff like that, right? And those come out because it's protecting in some way. So that's what it sounds like Cindy was talking about too, as well, with this person.
But one of the personalities, it was an abuser too. Did she mention that in the video? Did
Did
I
she?
pick up right?
Yes, she did
The
mention
video.
that. She mentioned that in the video.
Okay,
That
like
one
one
of the
of them. Oh,
personalities
yeah,
was
one of
also
them
an
does.
abuser, and she would wake up in places that you didn't know where she was, and
Yeah.
things like that.
And the
Yeah.
one
So,
would abuse her physically.
yeah,
It was named She or something like that. Yeah.
So that's interesting.
Yeah. So I guess the difference
Kind of.
is one is delusions and things like that, where the other ones are personalities that are there to protect or I guess abuse in some form.
And
but-
in her case, both, I think, because actually I think her brain was trying to deal with all the trauma.
Yeah.
And sometimes even the self-abuse in this case, or personality, was some kind of response to that.
Yes. Yeah.
I guess that's what makes me question the whole demonic versus just being a diagnosis, because this thing is abusing her, like it was abusing her, and that just that throws me for a loop on that.
Yeah.
And I know you can't call everything, a demonic possession, but that just, I don't know. That just throws
Yeah.
me. And I don't even know how you
That's a
even.
good point.
Yeah, absolutely.
That's a good point.
Okay, so there's one more thing that I want to show you guys here. and it's over personality disorder. Okay. So it's kind of them explained. Get you guys on here.
Hey everybody, today we're going to talk about personality disorders and how they differ or maybe don't from mental illnesses. But before we get into that, are you new to my channel? Welcome! I put out videos on Mondays and on Thursdays, so make sure you're subscribed and have those notifications turned on so you don't miss out. First, let's start by defining the terms. I've been mentioning this in videos recently because I think it's really important that we define terms prior to talking about them. So let's start by defining a personality disorder. Now, it's defined as a deeply ingrained and maladaptive pattern of behavior of a specific kind. It typically manifests by the time one reaches adolescence, and it causes long-term difficulties in personal relationships or in functioning in society. Without treatment, the behavior and experience is inflexible and usually long-lasting. Now, the pattern is seen in at least two of these areas. One, in our way of thinking about oneself and others. Two, in our way of responding emotionally to those around us. Three, our way of relating to other people. Or four, in our way of controlling one's behavior. I also think it's important to note that personality disorders are categorized into three main groups. The first group is called Cluster A, which holds the personality disorders that can cause us to act odd or socially withdraw from others. This includes paranoid personality disorder, schizoid, and schizotypal personality disorders. The second is Cluster B, and this holds the emotional, erratic, or overly dramatic personality disorders like antisocial, borderline, histrionic, and narcissistic personality disorder. And the third and final cluster, Cluster C, holds the more anxious or fearful personality disorders like avoidant, dependent, or personality disorder. Now that we've defined what the term personality disorder really means, let's talk about the term mental illness. Now, mental illness refers to a wide range of mental health conditions. These are disorders that affect your mood, thinking, and behavior. Therefore, mental illness is a collective term that refers to around 200 types of mental conditions, which are subcategorized into 5 main classes. The first is anxiety disorders. The second, mood disorders. Third, psychotic disorders or schizophrenia. Fourth, eating disorders. And the fifth, dementia. Now, among all the groups, anxiety disorders are the most common mental illness, just in case you weren't aware. Obviously, many people have mental health concerns from time to time, but a mental health concern becomes a mental illness when ongoing signs and symptoms cause frequent stress and affect our ability to function. After understanding the definition of each term, I think it's easy to conclude that a personality disorder is a mental illness, but it's a very serious one. And the reason that I say it's a serious one is because personality disorders are pervasive. They're not episodic. Do you remember the video I did a long time ago about bipolar disorder versus BPD and how the difference is that bipolar disorder is more episodic, right? It comes and goes in episodes, but BPD, borderline personality disorder, is more pervasive. It hangs around a lot. Personality disorders overall have been in our lives since we were young and can affect much of our day-to-day life, not to mention our relationships. Now, many people argue that the causes of personality disorders differs from other mental health issues, but I honestly think that it's too tricky of a thing to conclude. Different people have different coping skills and resiliency, and that's why siblings can go through the same things and come out very differently. We are all unique, and our mental health is not immune from that. That's why it's important that we see a professional and be properly diagnosed so that we can get the treatment that works best for our struggles. This video has been brought to you by the Kenyans on Patreon. If you would like to...
Okay. So that makes sense. So with personality disorders, they're over lifetime, right? So they're going to have this for a lifetime. When you look at borderline personality disorders, a lot of attachment issues in that. And it seems like in a lot of those personality disorders, they're caused by some sort of trauma and abuse in youth as well. but they're developed over time and they stay with you is the other part. So there's not really drugs or anything that can affect personality disorders because it's just part of you then. And the only thing is like say narcissistic, grandiose, elevated sense of self. But on the other side of that, there is self-esteem issues and things like that too, right? That cause. So they're trying to escape the low self-esteem by having grandiose thoughts of themselves. But it's over the whole life. And the only time that when they go in, people with these personality disorders, the only way that they can get help is that through self-awareness of it, right? And it being able to work themselves through it. That makes sense? Okay, so is there any type of anything in the DSM that we can kind of take a look at, maybe a video or whatever, that you would have questions about, thoughts about?
It's a lot. We need to go through
No,
that later,
I know.
piece by piece.
So generally, this is like, oh, this is something that takes a long time to go through, a lot of studying and things like that too. So that's why I say, man, get into your DSMs and read through, but always looking at what the criteria is for those, okay, and the differences in those criterias. But there's always a foundation of there are issues when they affect your family, your life in some way, your job, things like that too. And look at the prevalence of them. So when you go to diagnose, the funny thing is so like borderline, right? So there's attachment issues, there's trauma, there's things like that on it. And it's funny to listen to somebody. It's like if you listen to somebody, like even at Abundant Life or whatever, and we've got this room called the Grace Room, and within that, people can do collaboration and they talk and all that. It's funny they say, "Oh, I've got a borderline. I've got a borderline. I've got a borderline." You know, so many people. Like one person had 3 borderline. Not saying the Abundant Life, but somebody else that I was talking to. Well, I've got 3 borderlines. I'm like, wow. I mean, the prevalence of borderline is like 1%, right? It's so
1%
low.
of
It's
the
like
population.
there's no way you have 3 all at one time, unless you advertise for somebody who is, I want to know more about borderline, people, and that's who I want to work with, right? So the odds of you having 3 borderline people just coming to you is very, very low. Okay. So that's why I'm saying watch the prevalence on these things as well. And what's the differential diagnosis and all those things.
Is it true? Because one of my a person I interned with in my undergrad, she said that you'll kind of find that you'll draw a certain type of person or personality or whatever the issue is. Is that true?
So tell me what that means.
Like, so for instance, maybe you draw that type of person, a borderline. You'll tend to see those fairly often. Just based on your personality, she said that sometimes you draw people, a certain type of disorder or whatever. I don't know how true that is. I'm just asking.
Yeah, you know how I would look at that in a different way. How I would look at it is, and let me go back to, I had a person that I was supervising, and so I would supervise them, and then all of a sudden she had, I don't know, she had like 10 people she was seeing, and 5 of them were couples. And in every one of those, the male was narcissistic. Okay. I'm like, there's no way, right? This is happening. So, and the reason why I say that is, the problem is, so we did an investigation of her. So I would ask questions and did some investigation of her past or whatever. And there was narcissistic abuse in her life from I think, a previous spouse or something like that. So let me say this. So Felicia, what kind of car do you drive?
Kia.
An Kia?
Yeah.
Okay, so what type of Kia?
Oh shoot, I forgot the name of that thing. It's a boxy one. I can't even remember the name of it. It's the boxy.
Soul?
So,
Like
Soul. Yeah, Soul.
yeah. Okay. So what color is it?
Red.
So you got a red Soul. Okay.
Mhm.
So before you bought it, did you ever see any Kia Souls around?
No.
So you picked it out. Now, how many Kia Souls do you see?
A lot. And when I bought the car, I started seeing all red Souls everywhere.
Exactly. Right. Because you're paying attention to it now, right? And so it's prevalent to you because now you've seen it, you own one now, so now you see them all over the place.
Okay, I got you. I hear you.
Yeah. So it becomes part of you then too. And so you're really looking out for those types of things. So I think that's what was happening with this person. I had to be careful with it, but I mean, that's just the way it was. So I just think that you'll see more of it. So that's why I say we got to be so careful with reading through this book and diagnosing people and being self-aware of things and all of those things too, so that we don't diagnose wrong or things like that too. So I think that's what your friend was saying.
Yeah.
Is that we'll see more of those things because we're looking for those things, I guess. Yeah. So, okay, so let me bring up the final and then answer any questions that you guys have. Okay, so now that you've been through this, I'm going to open up the final and you could do it whenever you guys want to. And it's in the files. So I just opened it up and let's take a look at it.
And Doug, the slides will be in modules where we can find the slides from yesterday and today.
I'll have to put them out there.
Okay.
I think.
But that.
Why? Okay. I'm doing this. Right? Huh. You guys do me a favor, go out to, is anybody on Canvas?
Yeah.
Can you see the final?
Is that under assignments maybe?
Well, I put it under file. It's under files. If you go into files, can you see it there?
If you go to assignments, you can see final for diagnosis class doc. Yeah.
Oh, okay.
You can see if you go to assignments and final exam.
Okay. Because I went to files and opened it up, but it wasn't. Okay, so
it is a doc file. It's here. Question
and
1.
so you
question
can open
2,
up
3.
and look at it. It's available.
Yeah. Yeah, it is.
Okay, perfect. So let me open it up. So I just want to make sure you guys could see it.
Yeah, you can download it. It's working.
Okay, perfect. So let me bring you guys up here. Share my screen. Okay, so let's look through it. So question 1 here. So this is what I'm looking for, Alan, okay? List and describe the criteria for autism spectrum disorder. Please include the levels of severity outlined in the DSM. So and it's not just a copy paste or whatever. I want you to guys to go through and say, this is what autism looks like. So what page was that on, you remember?
50 something, or the last one.
Yeah, let's look at it. Like page 36, is that right?
Yeah. Yeah. 35, 36.
Page 56.
56.
56.
Thank you. Okay, so as you look through this, so list and describe the criteria. So you want to go through here and what's the diagnostic criteria? A and B, C, D, E, all of those things. And list that. And then the levels of the severity, right? What are those? Remember, requiring very substantial support, and then substantial support. So those. Question 2, the question involves differential diagnosis using one of the disorder categories listed below. Describe and define the criteria used to differentiate between 2 of the disorders. So look at the oppositional defiant and a conduct disorder. How do you differentiate those 2? Okay, so I want that. And you can pick one of the ones below, one of the 4, okay, and differentiate between those 2. Question 3, list and give the general diagnostic criteria for 3 of the anxiety disorders. So go through, look at 3 of the anxiety disorders and give the diagnostic criteria for those, okay? For 3 of those. And then question 4, discuss in detail the hallmarks of schizophrenia that we went through, right? Then describe how schizophrenia differs from schizophreniform. So there's a specific thing in the what the difference is, okay? Question 5, list and describe at least 3 general diagnostic criteria for personality disorders that differentiates personality disorders from clinical syndromes. And that's in the you'll see that in the diagnostic criteria, okay? So look for that. Then here's the fun part. Not that the other part wasn't fun, but this is fun. So question 1, look what we got. Read the following case and provide a diagnosis. Provide the symptoms that support your diagnosis and the rationale for a price. So remember when we did that, so you're looking through here. So Shiloh's a 23-year-old single white female and recent college graduate. He states that he almost did not graduate from college due to low grades and frequently missing class. So read through this. So remember what we did, went through the criteria. Why did I pick this? Because with Shiloh, he fits these things in the criteria from what I picked as the diagnosis, okay? So provide the symptoms that support it. Each symptom in here, include that in the diagnosis, okay? Provide the symptoms that support it and the rationale for arriving at the diagnosis, meaning, I picked this diagnosis because it wasn't these things in the differential. Does that make sense? So that's why we went through that exercise of going through the criteria for it and eliminating all the other ones. So I picked this one because of this criteria, and I picked it because it's not these things. Make sense? So I just don't want going along and so, okay, Shiloh's got X, and just leave it at that. I want to know how you came to that conclusion. Okay. So right underneath, here's my diagnosis, here's the criteria for it, and here's why I picked it, summary of diagnosis. Okay. So you can go through and populate that. So there's 1, 2, 3, 4 of those. Okay. And that's it. Easy. So here's the thing, you know what? You're all not going to come up with the same thing, and that's okay. It's not what you're coming up with. I just want to know how you arrived at it. It's the most important part. So just show, it's like algebra, show your work, type thing. Okay. So any other questions on the other assignments at all? Pretty straightforward, aren't they?
I did have one on the interview. Would it be, I know you put the LPC, can it be like a licensed social worker?
No, absolutely. Yeah, absolutely. Yeah, absolutely. Yeah. And if you guys need any help, I'm sure that we can find somebody at Abundant Life if you can't find another person.
Yeah.
I mean, we'll have plenty of people that help in that. Or you can interview me.
Yeah, that's nice.
Yeah. Okay, so let's get rid of this. Okay. So any other about the assignments or anything?
If we have any other questions later, we can email you, right?
Oh, absolutely. Yeah. Call me or whatever. Absolutely. Absolutely. You guys have my number?
No,
You
I
need to
have your
call?
email.
Okay. And the best is to probably email, if you guys have my email for work, I would probably get this quicker than Calvary, because I'm obviously at work all the time, and Calvary, I mean, I check it a lot more now than I used to, of course. But I would get it almost immediately the other way. Do you guys need it at all? Or did I give it to you previously?
You don't have it on here.
So it's Doug, if you want to write this down, Doug.Geiger, Geiger, at livingproof.co. Not .com, but .co.
Okay. I got you.
What are some things that stuck out to you today?
I really liked learning a little bit about more of schizophrenia whenever I was in my undergrad. In the physiological class that I took, we actually did a simulation of what maybe the voices would sound like. So like the conversation you guys had discussing about any demonic presence, and that was something that I kind of had thought about when I was hearing those things. It may not necessarily be demon possessed, but I do believe that there are forces, because we do face spiritual battles on a daily basis that
Yes.
can be inflicting these people still, of course, with us. Any person would be facing that. But I really enjoyed learning a little bit more about those things, and like learn about it too, because there's a lot more media, I would say, behind DID too, that has just a lot of misconceptions. And then, of course, for younger individuals, they're consuming the movies and shows and stuff about it. And I think there's a way that they fantasize that. And even though they may not struggle with it, be diagnosed with it, I think there's still things that people incorporate and kind of act as if that is an issue they do have. So that was just really
Yeah.
interesting to me.
That's so good. And so Lauren, on that sheet that I have on that Word document, it's got a simulation of did you watch it?
I haven't yet, but I'm going to.
Yeah.
I think it'd just be really interesting. I'm sure it's probably similar to what I had listened to before, but yeah.
Yes, it's pretty cool. It just lets me know that I would never have to live with that. Of course. Some other thoughts?
DID was really interesting to me. Dissociative.
Yes.
And
Yeah.
how there's so much stress and trauma that person, they can withhold it, so they create an alter to release it, I guess, or like
Yes.
step away from the reality of that stress.
Yeah, that's good. And here's the other thing is with borderline personality and DID, there's a form, it's DBT. So dialectic behavioral therapy. So that'd be something to, if you're interested in those two types of things, DBT is like probably the best. Yeah, there you go. Perfect. Dialectic behavioral therapy. That's an awesome book. And I use that book for a lot of things. It's got a lot of mindfulness stuff in it.
I'm
yeah.
sorry, I missed the book. I was writing something down.
Oh, sure. Yeah. She's got it here. Yeah.
Oh, I don't even see it.
It's
Tara
the
had-
Dialectical Behavior Therapy Skills Workbook, and it's McKay, Wood, and Brantley are the authors.
Do you see it, Felicia?
Yeah, Woods
Tara?
and McKay Woods and what?
And Brantley.
Right.
That's a really good book. I mean, I think everybody should have that one.
Just even the emotional regulation skills have been extremely helpful with people with anxiety even.
Yes. That's what I'm saying. Everybody should have that book. Every therapist should have that book. It's good. Okay. Anybody else?
Oh, the whole class was really good. I love the interaction and the inputs that I could hear from others and the
Yeah.
cases in the morning, everything. That's really
Good. Yeah. I wanted
Really
to
good.
ask you guys about that. How did you like that this morning? Incorporating, the supervision and everything this morning.
it's really
That was really
cool.
good.
Good.
Yeah. Really good.
I think it was good also just to, like, the counselor has, like, they're not alone in figuring out this issue, that they
Mhm.
have others to depend on and work together. And it's not up to them to solve everything, but they can bounce off ideas and new perspectives from
Mhm.
others. I thought that was really cool and
Yeah.
significant in counseling.
Yeah. And that's one thing I really want to build. And so picture Tara, she's in Minnesota, right? And she's not at a site where there's interaction. But did you feel alone at all, Tara? I mean,
No, I really didn't. And I think too, Professor Geiger is open anytime of the day to answer a question, even if it was like in between clients and I was like, okay, I have to ask you this question. You were available. So that was
Right.
extremely helpful.
Thank you. Yeah, absolutely. And that's important to me to be available. And that's why I'm saying email me at my work over the gallery when I'll get to you quicker. But because that is important to me.
Mhm. Yeah.
'Cause I know I wouldn't want to feel all alone in any of that stuff. Yeah. And so, I mean, that's what, with Tara being in Minnesota and Alicia was in Colorado. I have people in Tennessee. So people all over. I don't want them to feel neglected by any means. And I know it'd be easy to feel that way. So awesome. Okay. So if you have anything else, let me know. I'm going to stop this recording here.